Good morning, everyone. Welcome you all for today's session. And I would like to wait 1 or 2 minutes more to wait for others to join so that we can start at least by 10:03. Good morning, everyone. Once again, welcome you all for the today's another local chapter event. Today's topic, it's one of the very interesting, and I believe this is one of the hot topic anywhere in the revenue cycle, right? Because all the organizations want to be at the top level. They want to build top level of ENM always, right? So either the level 4 or level 5, that will be the top levels that every organization would like to build, because when they are handling patients like with complex care, they would like to build the higher level of ENMs so that every physicians will like they will be rightly paid for their skills and efforts that they spend with the patient actually. So when we see this topic here in LinkedIn, Ravi was presenting in Chennai. So we like that this topic, if it is presented, if it will be presented in our chapter, we were thinking that that will be benefiting most of our coders here, which in turn will help the organizations, because nowadays a lot of level restrictions are there. In those scenarios, if you are billing or if you're undercoding levels which actually should be of level 4 or level 5, which is literally going to be a very big loss for the organization, right? And also not only for organization, as a coder, when you code a level very low level, which actually it should be of a higher level, okay? So when you're undercoding something, this will bring up like a big audit concern, right? We are all audited by Tasnif. So this is one of the major error as well, right? So we would like to prevent those errors, and quality wise and compliances, we should be in a better level. So that's why we feel that this topic we feel that this topic needs to be presented in our local chapter, so that it can benefit all our coders and all the hospitals or medical centers which they are practicing here in Abu Dhabi. So, coming to the speaker selection, the topic tells how the speaker is, right? So, because such a vast topic it is, the number of slides is also more, and we feel that Ravi is one of the right person to deliver that topic. And when we found that this is being presented in Chennai chapter, we reached Chennai chapter to give the support, and they also gave the details of Ravi, and we met him. And not even a single time he ignored or he did not hesitate to take. I would like to thank on behalf of all our members, so for taking this opportunity to have a presentation in our local chapter, and also coming to his experience, he is more than 9 years experienced coder, and he is a CPC, CMC, and he has the quality certification LSSBB as well. So on behalf of all of you, I would like to welcome Ravi to present his session here today. Actually, welcome, Ravi.
Yeah, thank you, sir. Thank you, Abu Local Chapter, to giving the wonderful opportunity to present my PPT here, and thank you for all the audience to be participated here for your the next 1 or 2 hours. Okay, thank you so much for your presence. So today we'll be discussing about ultimate tips for coding moderate versus high level of office visit. So what all the objectives will be discussed today in the sense. So these are all the objectives we will discuss today. What is meant by evaluation and management, and what is meant by outpatient visit, and what is meant by new versus established patient, and what is meant by medical decision making, and what all the elements required for moderate versus high level of MDM. And we discuss about few sample reports, and we discuss about time-based recording. Finally, we'll discuss about DOH ENM rules and modifier 24 rules and consultations. So these are all the topics we'll be discussing today. So first we will discuss about what is meant by evaluation and management. So evaluation and management is nothing but whenever the patient visited to any specialty or any provider's clinic, first of all the provider needs to evaluate the patient. How they can do evaluate in the sense, first of all the provider need to discuss with the patient what is the reason the patient visited for, or what all the complaints the patient's having. Like that the provider need to evaluate the first thing. After evaluation the provider need to address the conditions. How they can address in the sense, they can order for any CPTs, they can order for any lab test, or they can order for any medications. So once the disease has confirmed, the provider will start for the treatment. The treatment only call it as management. So this is the purpose called it as evaluation and management. So nowadays all the providers will perform for the evaluation and management. Where we can find the CPT codes in the sense, the CPT code range should be 992022 to 99499 categories. We can found all the service of ENMs. So next we'll discuss about what is meant by office or outpatient visit. So office or outpatient visit is nothing but main purpose should be restore the patient well-being. So restore the patient well-being is nothing but whenever the patient presented to that, no, they'll be discuss about either new or existing health problems, concerns, or symptoms. Okay, how the provider will treat for the office or outpatient visit in the sense, they can prescribe any medications, or they can alternate any medications, they can order any lab test, or the provider refer the patient to any other specialty providers. This is called as office or outpatient visit. So in that office visit, we have two visit types. One is called as new patient, another one is called as established patient. So new patient is nothing but the patient who one has not received any professional services by the same physician or any other physician by the same group of specialty. That provider called it as, the type of patient called it as new patient within the past 3 years. So established patient is nothing but a patient already received multiple professional services by the same physician or by the group of physician in the same specialty group within the past 3 years. That type of call it as established patient. Here we want to look at one more thing. Without any ENM services or face-to-face services, the previously the provider performing for any interpretation of diagnostic test or reading X-ray or ECG, in the sense these things should not warranted for the established patient. Still we need to consider as a new patient only. If we need to consider established patient, means must required for the any ENM service or any one of the face-to-face service must required. So next we will discuss about what is the CPT codes are available for office or outpatient visit. We have the two type we discussed, right? The new patient CPT codes comes under 99202, 99203, 99204 and 99205. So 99202 called it as a straightforward medical decision making, or minimum it's required for 15 minutes must be met or exceeded. 99203 called it as low level of medical decision making, or minimum it's required for 30 minutes must be met or exceeded. 99204 called it as moderate level of medical decision making, or it's required minimum of 45 minutes must be met or exceeded. 99205 called it as high level of medical decision making, or minimum is required for 60 minutes. Same like established patient, call it as 99212, 213, 214 and 215. 212 call it as a straightforward medical decision making, or minimum 10 minutes must be required. 99213 call it as low level of MDM, minimum 20 minutes must be required. 99214 call it as moderate level of medical decision making, minimum 30 minutes must be required. 99215 call it as high level of MDM, and minimum 40 minutes must be met or exceeded. So here we are discussing MDM. What is meant by medical decision making? So next we'll discuss that only. So medical decision making is nothing but how the provider rate their degree of treating the patient's health conditions. Okay, so this is the provider choice, how they'll be rate the degree. So in that MDM, we have the four types. What are the four type in the sense? One is a straightforward, low, moderate, and high levels. How we can choose this any one of the level in the sense? First of all, we need to learn about the three component. In the three component only determine the overall level of MDM. So if it is at least two components indicate the same level of MDM, means that the level should be considered as the overall level of MDM. If it is the three components fall in the different three categories, then we can consider middle one point as the overall level of MDM. So what are the three component in the sense? The first component should be called it as number and complexity of problems addressed at the patient encounter. So second component called it as number, the amount and or complexity of data to be reviewed and analyzed. The third component called it as a risk of complication and or morbidity or mortality of the patient management. So we'll discuss one by one. First, we'll discuss about number and complexity of problem. So number and complexity of problem is nothing but what is the reason the patient visited for, and what is the conditions the provider treated on the patient visit on that day. Okay, for example, if the patient visited for hypertension, heart failure and diabetes, during the day what the provider will be treated, either the provider treated for three conditions, or they'll be addressed to only hypertension or any other particular single condition they'll be treated. So this type of conditions only called it as number and complexity of problems. So next we'll discuss about amount and or complexity of data to be reviewed and analyzed. This is nothing but what are all the documents the provider utilized to treat the patient condition. Document in the sense it should be the lab results, imaging studies, medical history or other relevant information. Other relevant information is nothing but history collecting from other persons. Okay, so these are all the things called it as amount and or complexity of data. So next we'll discuss about risk of complications. So risk of complication is nothing but we are all know very well, it should be the complete treatment. Okay, so once the disease has finalized, what is the treatment the provider will be started? Either they'll be given any medication, or they can start any surgery, or they can refer the patient to any other particular specialty providers. This is called it as a risk of complications. So we have the one fun activity. Here we have the images. Okay, look, find out the images and tell me what is the number and the complexity of problems able to find out here. Okay, I'll give the 30 seconds. You guys can guess it. We'll check on the answers. Yeah. So again, I will give the clue. This is fall under the number and the complexity of problems point. Okay. Yeah, sure, sure. So the answer should be acute illness with the systemic symptoms. Acute illness system symptoms. Call it as acute illness with the systemic symptoms. We'll move on to next. Next, we'll discuss about the component one, number and the complexity of problems required for moderate and high levels. So what are the points required in the sense for moderate level? We require one or more chronic illness with the exacerbation, progression, or side effect of treatment, or else two or more stable chronic illness, or one undiagnosed new problem with the uncertain prognosis, or one acute illness with the systemic symptoms, or finally one acute complicated injury required. For high level, we required one or more chronic illness with the severe exacerbation, progression, or side effect of treatment, or one acute or chronic illness or injury that poses a threat to life or body functions. So we'll discuss one by one. First of all, what is the moderate level? So moderate level complexity always required for the provider attention. Okay. So without provider attention, we can't able to treat the condition. For example, a patient already performed for a surgical repair. It's totally completed for more than 8 weeks. Okay. So the wound is not healing as expected. Okay. We can call it as it's a delayed healing. So these type of conditions always required for moderate complexity evaluation. Why? Because its additional treatment must required. So next we'll discuss about component one, chronic illness with the exacerbation, progression, or side effect of treatment. So what is meant by exacerbation? Exacerbation is nothing but the condition actually getting worsening, or sometimes the provider will document it as poorly controlled, uncontrolled, or severe exacerbation or moderate exacerbation. Like the statement they'll be given means we can consider the exacerbation status. Progression is nothing but the condition evolving one stage to another stage. For example, CKD stage 2 to stage 3, or else ulcer, pressure ulcer stage 1 to stage 2. This type of condition we can consider as a progression. So side effect of treatment is nothing but before starting the treatment, the provider need to control the side effect of the condition also. For example, chemotherapy. So whenever the provider starting for any chemotherapy, definitely it will be having many side effects. So the provider first giving the side effect treatment also before proceeding the chemotherapies. So this is called it as one chronic illness with the exacerbation, progression, or side effect of treatment. We'll look at the examples. So here the product documented mild intermittent asthma with acute exacerbation, moderate persistent asthma with exacerbation. Both the conditions as chronic, directly they'll be documented as the exacerbation status. Here the mild and moderate both should be considered as the asthma type. Hence, we can't be able to consider it's a exacerbation status. The product need to say separately for the exacerbation. So next we'll discuss about two or more stable chronic illness. So chronic illness is nothing but as per the CMS guidelines, any condition that be persisted more than 1 year and it will be impact the life until the death means we can consider the condition as a chronic. Okay, here the stable in the sense after started the treatment, okay, the chronic conditions as not elaborated or is not decreasing, okay, it will be maintaining as a normal level. This type of conditions only we can call it as a stable chronic illness. For example, here the provider documented essential hypertension. They clearly mentioned it's a chronic at goal. At goal in the sense in the bracket they clearly mentioned it's a stable. Next condition they'll be documented as mixed hyperlipidemia. They clearly mentioned it's a improving stage. Then both the condition considered as the chronic condition with the stable also. Next we will move on to undiagnosed new problem with uncertain prognosis. So undiagnosed in the sense without confirming any diagnosis. Most of the time the provider will document it as a differential diagnosis like MI versus CAD or versus condition or ruled out condition or concern conditions. Those types of conditions only we can consider as a undiagnosed new problem. With uncertain prognosis in the sense without medical intervention anything can happen to the patient for this type of conditions. Okay, for example, here the patient came with the complaints for a right knee pain. Here the provider ordered for MRI knee without IV contrast. Here the provider not all document any versus condition or concern condition or ruled out condition, but we need to read the plan carefully. I discussed the diagnosis and treatment plan with the patient. At this time, she does have a lot of guarding and she does have a moderate effusion. I am concerned for an ACL rupture. ACL in the sense anterior cruciate ligament rupture. That's the reason the provider ordered for MRI right knee. Hence, we can consider this a undiagnosed new problem category. And one more important thing, whenever the provider ordered some test, okay, the additional radiology test, the results is came, okay, either it should be the confirmed the diagnosis or it's no acute findings like that. Once the result came means we can't able to find again for the undiagnosed new problem categories. So without result, still we can consider. So next we will discuss about acute illness with the systemic symptoms point. So systemic symptoms in the sense, few of the symptoms we can directly consider for the systemic symptom, that general symptoms like fever, body ache, fatigue, myalgia, and some of the condition symptoms we can directly consider as a systemic symptoms. The systemic symptoms may not be general, but maybe single system of symptoms also we can consider as a systemic symptoms. So for example, here the patient having suppurative otitis media of both ears. So most of the common symptom for suppurative otitis media is should be ear pain. However, the patient here having the appetite changes, fatigue, fever, congestion, ear pain, rhinorrhea, cough, and myalgia. So the appetite changes, fatigue, fever, myalgia, and all considered as a general systemic symptoms. Then we can assign for the directly moderate level. So next we'll discuss about acute complicated injury. So complicated injury is nothing but they require for additional organ evaluation also. For example, the patient having head injury with a brief loss of conscious, multiple fracture and multiple injuries. So here head injury with a brief loss of conscious in the sense the provider need to evaluate for the head injury also, and the provider need to evaluate for the additional organ of brain, and they need to evaluate for the nervous system also. What is the impact should be happening? So that is the reason they always required for the additional organ evaluation also to examine. So for example, here they'll be documented SDH, subdural hematoma, subarachnoid hemorrhage, and intracranial hemorrhage. So what will be happen if the provider not treated well about this condition? Definitely it will be lead to paralysis of the patients, or it will be lead to brain death, or it will be lead to coma also. That is the reason the additional organ examination must required. So next we will discuss one more example we have. So this also fall under the number and the complexity of problems. Again, I'll give one chance. Just try to find out. Okay, thanks for guess. I'll show the answer. The answer is chronic illness with the severe exacerbation. Chronic illness, severe exacerbation. So we'll move on to next. Next, we'll discuss about high level. So high level of complexity always happened. It's a unstable and unpredictable characteristics. So in that, what is the component one point requirement in the sense chronic illness with the severe exacerbation, progression or side effect of the treatment. The chronic condition should be always in the severe exacerbation, like it should be diabetes with the diabetes ketoacidosis. Progression in the sense same like CKD stage 2 ESRD or stage 3 to ESRD conditions, or else pressure ulcer stage 3 to unstageable. Okay, if the product documented, these are all the terms in the sense we can directly consider it a severe exacerbation progression category. Here we have the example hypertension urgency. So whenever the patient having hypertension, suddenly they will be admitted with the reason for any urgency, emergency or crisis in the sense we can directly consider it's a chronic illness with the severe exacerbation category. One more example we have diabetes with the ketoacidosis. The patient having DM with the DKA simply called it as. Okay, this condition also we can consider in the high level of category. So next we'll discuss about acute or chronic illness or injury that poses threat to life or body function. So this is nothing but the condition once it will be affected the patient health means it should be the question mark about the patient conditions. Okay, either it should be recovery or it will be lead to death. Those type of condition only we can call it as high level. So example acute myocardial infarction, simply we can call it as silent killer of heart attack. Next pulmonary embolism, severe respiratory distress, progressive severe rheumatoid arthritis, psychiatric illness with the potential threat to self or others. For example, suicidal ideation and homicidal ideation and all, it will be fall here. Next, peritonitis, acute renal failure or an abrupt change in the neurological status. This type of conditions and all fall under this category. Example we have sickle cell disease with the acute pain crisis. So sickle cell in the sense whenever the RBC shape should be changing, that condition called it as sickle cell. So the use of RBC should be carrying the oxygen and the nutrition to the all tissues. Once the nutrition and oxygen not reached to the tissue means definitely the tissue death will be happen. At the time the patient will feel for the severe pain. Okay, this type of condition also fall under the high risk. So next we'll discuss about MDM component 2 point. Component 2 point is nothing but the amount and or complexity of data to be reviewed and analyzed. So here moderate and high levels we have three categories. Both should be the same category only. However, moderate level we required out of three any only one category required. For high level we require at least two category out of three. So what is the category in the sense? The first category called it as test document or independent historian. Category 2 called it as independent interpretation of test. Category 3 called it as discussion of management or test interpretation. We'll discuss one by one. So first category, so test document or independent historian. So here what all the point required in the sense a review of prior external note from each unique test, a review of result from each unique test, ordering of each unique test, assessment requiring an independent historian. So we'll discuss one by one. So first point, a review of prior external note from each unique source. So a review of prior note in the sense it should be the different specialty providers. For example, our provider should be the primary care physician. The patient came with the complaints for diabetes mellitus. The patient already treated the condition with the endocrinologist or some other specialist in the sense our provider will reviewing the prior documents of endocrinologist. Then we can give the point here like prior external notes review point. So next in the sense a review of results each unique source. So review of results is nothing but this also the test ordered by some other specialty providers. Our provider will doing the review. If the same specialty provider ordered and the same specialty provider review the test in the sense we can't able to consider as a review of results points. So here each unique test we can consider as a one point. For example, our provider reviewed for the CBC, BMP in the sense each should be considered as a unique point. CBC we can give 1 point, BMP also we can give one more point. So totally we can consider 2 points here. So next we'll discuss about ordering of each unique test. So each unit test, each lab should be considered as the unique test. A unique test is defined by the CPT code set only. A panel should be considered as a only one unique test. Okay. If the provider ordered the test, however, the patient declined the test means that also we can consider. However, the patient not necessarily required for the test, the patient requested to do the test means that also we can consider as a unique point. So for example, here the provider ordered for COVID-19, influenza A and influenza B. Anyway, we have the panel CPT code for 87428. Since we need to consider this is a single test, okay, not for a three test. So hence we can consider only 1 point for these three tests. In the same case, the provider ordered for same like CBC separately, CMP separately in the sense we can consider 2 points for the each orders. So next we'll move on to this is an example. Here for screen for sexually transmitted disease, the provider ordered for hepatitis B surface AG, hepatitis C, and HIV 1 plus 2 and RPR. Okay. So each point we can consider one. Okay. So next we'll discuss about assessment requiring independent historian. So independent historian is nothing but the history obtained from either parent, guardian, surrogate, spouse, and witness. Okay. So for before considering this independent historian point, we need to think about two questions. Why the patient can't able to provide the history? What are the reason the provider can't able to provide the history in the sense either it should be the children or elderly patients or individuals with any developmental delays, okay, individual with any psychosis conditions. These are all the scenarios the patient can't able to provide the history. Next thing we need to look at the document who will be provided the history apart from the patients. These two conditions definitely we need to check with the documentation to considering for the independent historian point. Here we have the example. 10-year, 11-month-old male patient presents with the complaints of cough and congestion. Patient is accompanied by grandmother and she states his symptoms started 3 days ago. Patient's mother wanted to him get checked out because they are going on a cruise this Wednesday. So here the history provided by grandmother. Then we can consider the 10 years old we can consider as a developmental stage. So next we'll discuss about the category 2, independent interpretation of test. So independent interpretation of test performed by another physician or other qualified healthcare professional. So when we can consider this point in the sense the other specialty provider ordered the test, however our provider giving the interpretation alone, then only we can consider for the independent interpretation of test. For example, here given as the urgent care provider, the patient came with the complaints for some of the ankle pain. The urgent care provider ordered an X-ray and they'll be sent the copy of X-ray with the orthopedist. The orthopedist reviewed the results and they'll be giving for the independent interpretation of the X-ray in the sense we can give the credit to orthopedist, not for the urgent care provider. What is the main category we need to check in the sense whenever you're considering for independent interpretation of test, the test should not be ordered by our provider. Our provider need to give only for the interpretation. And one more important thing, if you are billing separately for the interpretation means we should not count this point. For example, PCP ordered the EKG, however the cardiologist giving the interpretation. We are separately billing for the ECG in the sense we should not consider for the category 2 point. So here is an example. Chest X-ray interpreted by me reveals increased interstitial marking in the lower lung field. And one more important thing, the independent interpretation always fall under the radiology test only. Any radiology or special studies only. This will not consider as the lab test. Lab test should be considered as a review point only, not for the independent interpretation points. So next we'll discuss about discussion of management or test interpretation. So discussion of management or test interpretation, nothing but that the patient condition or management should be discussed with any other specialty providers. Okay. For example, if the same specialty providers discussing about the patient cases in the sense that should not be considered, or else the provider discussing the patient health conditions with the family members in the sense that also should not be considered. If the resident discussing the patient condition to the MD in the sense that also should not be considered. This should be involving in the different specialty providers. For example, our provider should be the cardiologist. The patient came with the complaints for chest pain. The provider ordered for CT chest. However, there is no cardiology standpoint any disease. Okay, the provider discuss the management options with the pulmonologist. They'll be sent the copy of report also. The pulmonology identified the patient having lung disease, okay, like lung mass like that, and then they'll be discussing about what is the best treatment for lung mass. Either we can go biopsy or they can start about any treatment like that. So this is called it as discussion of management or test interpretation point. Again, I'm stating this should be involving the two different specialty providers. So here we have the example. So the date of service is 10/13/2024, presents with the complaints for some pain and reasons. So here our provider, I discussed the case with Dr. Delos Reyes and he will be planned for bypass surgery in the morning. So our provider discussed the patient cases with some other vascular provider. They'll be planned to do bypass surgery in the morning. Then this we can consider as a discussion of management. So next we'll discuss about MDM component 3 point. It's fall under the risk of complications. So what is the requirement for moderate and high level? So moderate level always required for prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors, decision regarding elective major surgery without identified patient or procedure risk factors, diagnosis or treatment significantly limited by social determinants of health. For high levels, it's always required for drug therapy requiring intensive monitoring for toxicity, decision regarding elective major surgery with the patient or procedure risk factor, decision regarding emergency major surgery, decision regarding hospitalization or escalation of hospital level of care. Finally, do not resuscitate or de-escalate care because of poor prognosis. The last point should be parental controlled substances. We'll discuss one by one. First, we'll discuss about moderate level of prescription drug management. So prescription drug management in the sense whenever the patient visited with any complaints, the provider given for additional prescriptions, the drug they'll be prescribed means that we can consider. So what all the standpoint we can consider as a prescription in the sense the provider documentation should state, okay, start some medications, either it should be the amoxicillin or any other medication. The start word we can consider as a prescription, or sometime the provider documented as continue the with the medication name and the use route of uses everything. Okay, this continue also we can consider. And the product mentioned about discontinue the medication due to some of the side effects. For example, the patient taking for aspirin, suddenly they'll be started for GI bleeding. Okay, then the provider immediately advised to stop the medication. That also we can consider as a prescription drug management. Next, the provider discussed with the benefit of some medications. However, the patient declined the medication due to some financial issue or some other reasons. Still, we can consider this as a prescription drug management point. Next, sometimes the provider will be increase or decrease the medication dose based on the patient condition. For example, patient having hypertension, still it should be poorly controlled, in the sense the provider will increase the medication dose. Or for the diabetes condition, the provider already prescribed for insulin with the 20 units per day. However, suddenly it will be goes for hypoglycemia, means then the provider will decrease the dose of insulin. So these are all the management we can consider as a prescription drug management. So main important thing in the sense, these are all the management the provider documented in the assessment and plan. Then only we can able to consider for the prescription drug management. So we should not consider for the current medication list and all. Okay, so that should not warrant. Example here, assessment, the patient came for the vaginal discharge and sexually screened for sexually transmitted disease. For vaginal discharge, the provider ordered for tinidazole and a duflocan tablet. Both should be considered as the prescription drug management. So next we'll discuss about decision regarding minor surgery with identified patient or procedure risk factor. Either the surgery should be minor or major, it should be decided by the provider itself, not based on the global days. Okay. So however, we have the global days like 0 to 10 days will be considered as a minor. 90 days should be considered as a major, even though if the provider documented the 10 days global period procedure should be major, in the sense we need to consider based on the provider only. So here the risk factor, either it should be the patient or procedure risk factors. The risk factor should be mentioned by the provider only. What is the risk of patient, in the sense we can say the age is the first risk. For example, if it is the less than 1 year, means it's too difficult to do the any surgeries. Same like it should be the 8 years and above, in the sense that also too difficult to perform the surgeries. Why? Because the healing will be getting delayed. Okay, that is the reason patient age should be considered as the number one risk. Number two, in the sense the comorbid conditions. So comorbid condition, in the sense we can say it as diabetes, asthma, hypertension, CKD. This type of conditions, the comorbid condition also impacting the surgery. For example, the patient having DM with the hyperglycemia, in the sense the provider will never do for the surgery until controlling for the glycemic level. So that is the reason we can consider this as a risk of patient. Next, procedure risk, in the sense the provider need to document about the procedure risk like bleeding, any puncturing the drug or paralysis. Okay, during the procedure anything can happen. Sometimes bleeding can happen, or sometimes unfortunately the provider will cut the remaining organs also, or sometimes vitals abnormality can happen. Okay, so these are all the things called under the procedure risk. So either it should be the patient risk or procedure risk, the provider need to explain in the documentation. Then only we can consider with the identified risk factors. For example, the patient came with the complaints for positive fecal occult blood. Okay, the provider will plan to do for EGD and colonoscopy. EGD is nothing but esophagogastroduodenoscopy, and they will be planned to do colonoscopy also. The provider clearly explained about the risk of procedure detailed, which is nothing but anesthesia complications. Sometimes they'll be happen for perforation, bleeding, and sometimes they can lead to infection also. Like this, the provider need to document in the risk. Then only we can able to consider for the risk of patients. So next thing we'll discuss about decision regarding elective major surgery without identified patient or procedure risk factor. Elective major surgery is nothing but it should be the pre-planned surgery. For example, the patient having appendicitis, then the provider will decide to do the appendectomy after 1 week or after 1 month, like that. Okay, it should be the planned surgery, that is called as elective major surgeries. So in that example, they'll be documented he will need surgical intervention with open reduction internal fixation of finger fracture. So the patient having the finger fracture, the provider will plan to do for O or IF. When they'll be scheduled, in the sense they'll be scheduling for Friday morning upcoming days. Okay, so this should be considered as a elective major surgery. So next we'll discuss about SDOH. There is nothing but social determinants of health. So what is meant by social determinants of health? Is nothing but the few of the patient condition like where they'll be born, where they'll be live, and where they'll be grow, work, and where they'll be aged in. Okay, these are all the conditions will impact the patient health. In the sense we can consider those type of condition as a social determinants of health. For example, Dr. Andre described the case of young man with a knee injury presenting for an initial evaluation. It is determined that should have an MRI be referred for a orthopedist and remain non-ambulatory until his pain resolves. But he has a low-paying job with no health insurance. So that the reason the patient refuses for the MRI and the referral both. So here low-paying job with no health insurance also we can consider as a social determinants of health status. So these are all the SDOH conditions the provider need to document. Then only we can able to consider. So here is the examples. So homelessness also we can consider, the no health insurance also we can consider, illiteracy also we can consider, and the living alone also we can consider. These are all the examples. So here the chart example, they'll be documented as home safety, documented living alone, lives alone. Okay, this we can consider as a SDOH status. So next we will discuss about high level of MDM, high risk. Okay, so drug therapy requiring for intensive monitoring for toxicity. So intensive monitoring is nothing but whenever the drug is injected, the provider need to monitor the toxicity, not for the therapeutic effect. Therapeutic effect in the sense after giving the treatment how the condition should be decreased, like that. But toxicity in the sense what are the additional effect they'll be created to the injuries. Okay, like that. So the monitoring for toxicity only we can fall under the drug therapy requiring intensive monitoring for toxicity. For example, chemotherapy. Whenever the patient having any cancer condition, if the provider given for any anti-neoplastic agent called it as chemotherapy, the chemotherapy not only killing for the cancer cells, it always kill for the normal cells also. That is the reason every cycles of chemotherapy, the provider need to check for the cytopenia or all the blood levels. They need to check for the hemoglobin, everything. So monitoring in the sense it should be required for any lab test or psychological test or any imaging test. So without any test, if the provider monitoring by history or examination in the sense that does not qualify for the monitoring of toxicity. So we have the few drug samples. These are all the drugs must required for the continuous monitoring for toxicity. Some of the cardiac drugs we can call it as digoxin, digitoxin, quinidine, procanamide, amiodarone. Okay, so this will be helps to treat for congestive heart failure, arrhythmia, angina conditions. So next anti-epileptic drugs, phenobarbital, phenytoin, valproic acid, carbamazepine. So it will be help to treat for the epilepsy, prevention of seizure. Next bronchodilators used to treat for the theophylline, caffeine. So this will be used to treat for asthma, COPD, and neonatal apnea. Anti-cancer drugs, all the cytotoxic agents, it will be treated for multiple malignancies. Insulin and anti-diabetic drug, they'll be provided in the intravenous insulin. So insulin, most of the drug route is nothing but it's a subcutaneous only we will be injecting. But however, the product given in the intravenous insulin in the sense it should be required for the continuous monitoring like hyperglycemia conditions. So next we will discuss about decision regarding elective major surgery with identified patient or procedure risk factor. We already discussed separately for what is elective major surgery and what is the risk. Here we have the example. So again, I again discussed with the patient regarding the risk and benefit of left radical nephrectomy. So the provider will plan to do the nephrectomy. Nephrectomy is nothing but removal of kidney. So they again the provider will be discussing about the risk. Risk include but not limited to pain, infection, bleeding, injury to surrounding structures, which includes the spleen, pancreas, vascular structures, bowel, positive surgical margin, incomplete tumor resection, or needing for additional therapy for the kidney tumor and the incisional hernia, bowel obstructions. Okay, so these are all the risk the provider need to document. Then only we can consider say with the identified risk factors. So next we'll discuss about decision regarding emergency major surgery. So emergency major surgery is nothing but the surgery need to perform within 48 hours of admission. Then only we can consider this type of surgery as a emergency major surgery. Here we have the example. The patient age is 75 years old Female, whenever they'll be come out of from the work, no, patient was at the restaurant and while coming out, she tripped and fell without loss of conscious. So after fell, the patient sustained as a right femoral neck fracture. Then the provider planned to do OR today, or in the sense operation theater, they'll be planned to operate today. So what is the plan they'll be planning? In the sense, right femoral neck fracture after mechanical fall, plan for operation today, contact surgery team, any anticoagulation issues and transfusions. So immediately they'll be operate the condition. Then we can consider this as a emergency major surgery. One more easiest example, whenever we consider for the emergency major surgery, no, whenever we are utilizing for 57 modifier decision regarding major surgery. So if you are utilizing for 57 modifier in the ENM means, then we can consider it should be the emergency major surgery categories. So we'll move on to next. Next we'll discuss about a decision regarding hospitalization or escalation of hospital level of care. So decision about hospitalization is nothing but if the patient had came with the office with the complaints for myocardial infraction. So definitely we can't able to treat the MI in the office setting. That the reason the provider will decided to admit the patient immediately in the hospital setting. Then we can consider the decision regarding hospitalization. So next point in the sense, escalation of hospital level of care, same like, so either the provider will decide to admit the patient or the provider immediately transfer the patient to any nearest emergency department. In the sense, this is called as escalation of hospital level of care. Okay, both the point will be supported in the high level of care. For example, here the patient having acute respiratory failure, febrile illness. Okay, here the patient will be transferred via ambulance with the nearest emergency department, and the provider will discuss about the emergency department doctors also to treat the conditions. Then this type of transfer we can consider as a high level. So next we'll discuss about do not resuscitate or de-escalate care because of poor prognosis. So DNR is nothing but do not resuscitate. Simply we can call it as CPR. Okay. So whenever the patient condition is life threatening, okay, at the time only most of the protocol will attempted for the CPR. So whenever the breath has stopped and the heart has stopped, no, at the time they'll be start for the CPR. While they will be providing for CPR, no, it will be high risk. Within the 60 seconds, they need to give for the 60 chest compressions, and they need to give for the mouth breath also. Imagine if the patient age is more than 70 years and above, if the provider giving for the chest compression, what will be happen to the patients? So either the patient should be stable due to that osteoarthritis condition or bone weakness, definitely the provider will broken for the few ribs. Okay, so after recovering from the disease, the patient need to still come to the hospital with the complaints for rib fracture. That is the reason the few patient they'll be decided do not resuscitate. In the sense, they don't want any aggressive treatment when they have critically ill situations. So this type of DNR only we can consider as the high level. So the provider need to state about the DNR status in the documentation. Then we can consider for high level. Here is the example. In that example, assessment and plan, patient having unstable gait and FTT also due to generalized weakness and B12 is normal. PTOT evaluation and treatment. I spoke with the patient about his DNR core status and he confirmed he does not want to be resuscitated or intubated. Here the provider agreed they do not want any CPR and all. So in this type of document we can consider for the high level categories. So next we will discuss about so de-escalate care because of poor prognosis. Poor prognosis refers to an estimation that is a low chance of recovery from the disease. Is nothing but there is no hope to recover the patient from the disease. This type of condition called as poor prognosis. For example, the patient having multiple metastasis of cancer. So even though we are giving any aggressive treatment or the entire level of treatment, in the sense, even though the patient prognosis should be low only, we can't able to recover the patient. Okay, either the lifespan should be up to 3 months or 6 months only. This type of conditions only called it as poor prognosis. Here we have the example. In that example, The patient having acute respiratory failure with hypoxia, hypercapnia, secondary to complete occlusion of the right main bronchus, with the patient also having for post-obstructive pneumonia, and the patient also having for squamous cell carcinoma in the lung, and the patient additionally having persistent atrial fibrillation, acute on chronic diastolic heart failure, bilateral lower extremity edema, CAD, and the patient having for renal cell carcinoma, gout, Barrett esophagus, and the AKI, acute kidney injury, that's staged for CKD chronic 3, and the patient also having for symptomatic anemia, which is dropped from 8.3 to 6.8. So this all the condition is definitely not manageable. That the reason the provider documented as poor overall prognosis, wishes to discuss the things further with oncology. So this type of statement we can directly consider for the high level. So no management is required for this type of condition. We can let them to be live and peaceful death. So next we'll discuss about finally parental controlled substances. So parental administration is nothing but the injections or any medications administered other than oral and rectal route. If the medication administered by other than oral and rectal route, that is called it as parental controlled substances. So parental route. So controlled substance in the sense it should be treating the life-saving drugs. For example, what all the parental route available in the sense that should be intravenous route. So it will be delivered directly into the vein, which is the fastest and the most direct route intravenous. Intramuscular injections, they'll be injected directly into the muscle, which allows the absorption over a longer period of time when compared to the IV. So if it is sudden cardiac arrest means most of the drug they'll be giving us intravenous only. However, the patient having any back pain or any other abdominal pain, they'll be giving the injection into the muscle only. Why? Because it's a longer period of time it will be getting the relief. Subcutaneous, they'll be injected into the fatty tissue beneath the skin, which is beneficial for medication that require slower and sustained absorption. For example, insulin and all. Insulin and all mostly they'll be injecting in the subcutaneous only. The action should be slower and sustained absorption. The next route should be intraosseous. Intraosseous is nothing but directly delivered into the bone marrow. So, for example, if the patient having any bone marrow cancer, leukopenia, and all this type of condition, they'll be directly injected in the medication to the bone marrow. Next should be intradermal. So injected into the dermal layer of the skin. Okay, most of the allergy testing, if the provider giving for any antibiotic before giving the medication, the provider will do for the test dose. The test dose only called it as they'll be injecting in the intradermal region. First, they'll be checking for any allergy reactions. Once the patient not having any allergy, then only they'll be injecting for the medications. Next, intra-articular. They'll be injected into the joint space. Most of the joint space injections we can consider as a intra-articular. So this type of parental other than parental routes will be available. If the provider injected for any controlled substances in these routes means we can directly consider for the high level of care. For example, here the patient having sickle cell disease with the acute pain crisis. Here the provider injected for diluted with IV 4 mg. Then the diluted we can consider as a controlled substances. They'll be injected in the parental route of IV. Then we can consider this as a high risk. Okay, we can consider for the high level of management. So here we have the few sample reports. In that sample one, the patient having heartburn and the pain in the left side. Okay, that unfortunately documented as a right side. In the below, they'll be documented. Patient reports left-sided chest pain that radiates from the left arm down to the hand. It comes and goes. Nothing make it worse. Nothing make it better. Okay. So the patient visited with the complaint for left-sided chest pain. So here the provider documented the condition as unstable angina, mixed hyperlipidemia. Along with they'll be documented BMI also. Due to that unstable angina, the provider concerned that is the unstable angina due to pain intermittently worsening, but a acting lasting for hour and discussed with should be the acute coronary syndrome. Then the provider discussing the unstable angina should be maybe the acute coronary syndrome. That is the reason the patient transferred the to emergency department. I told the patient I would like to call her an ambulance to get to the ER directly. So the provider discussed to call for the ambulance. However, the patient refused the ambulance services. They not at all want any ambulance services. However, they suggested I'll go to home first like that. But the provider clearly said first the patient need to go for the ER due to the patient condition status. After that, the patients agree they'll be go to the ER directly. So this is called it as transfer of care immediately. Okay. This it will be fall under the high level. So we'll find out the rationally. First, table A supported for acute or chronic illness or injury that poses a threat to life or body function called as unstable angina. Table B supported for none or minimal, nothing they'll be ordered. Table C fall under escalation of hospital level of care. Okay, they'll be transferred immediately to the emergency departments. The overall level supported for high level 99215. So next, one more sample report we have. The 72 years female with the history of asthma who presents with a cough and wheezing states her cough started 11 days ago. So the patient visited the complaint for cough and wheezing. The patient already having a asthma. Okay. So the patient no history of pneumonia, COPD, heart disease, any blood clots and all. So here the product documented in the assessment, the patient having URI. URI is nothing but upper respiratory infection. CAP is nothing but community acquired pneumonia. Due to that community acquired pneumonia, the product reviewed for the COVID-19 which is negative. Influenza A that also negative. Chest X-ray also unremarkable. Due to that next wheezing the patient having. Next for moderate asthma with acute exacerbation condition, the provider reviewed the chest X-ray which is already unremarkable. Previous asthma exacerbation they have treated with per oral steroid and albuterols. So what is the plan the provider given here in the sense? For URI, nothing they will be given for treatment. For community acute pneumonia, the provider started for azithromycin 250 mg, next acetaminophen 500 mg they will be started, and they'll be advised to use Mucinex extended release 600 mg. For wheezing, nothing they will be provided. For moderate asthma with acute exacerbation status, again the provider advised to continue the inhaler 2 puffs every 6 hours. They will be given the refill also, and additionally they will be given for prednisone 20 mg. That Deoneb also they'll be additionally treated given. So here based on the conditions, moderate asthma with acute exacerbation, we'll check the rationally which level this will be supported. So table A supported for one or more chronic illness with exacerbation, progression or side effect of treatment, which is fall under the asthma with the acute exacerbation category. This fall under the moderate level. So next at table B, three results are reviewed like COVID reviewed, influenza reviewed, and chest X-ray also reviewed. 3 plus results fall under the moderate level. Next at table C, prescription drug management, like they'll be started for the azithromycin 250 mg tablet. This also fall under the moderate level. So three component will be fall under the moderate level. Then we can consider the overall level should be the moderate 99214. So next we will discuss about the time-based coding. So as per 2021, they'll be explicit the overall time alone we can consider for the level of MDM. So as per 2023, they have revised some changes. They'll be removed for the range of time and they'll be fixed for the minimum time should be the overall time. However, as per the Abu Dhabi guidelines, we should not consider the time-based coding. We need to follow only for the MDM-based coding only. This is the main instruction for time-based recording. Next, we will discuss about DOH ENM rules. DOH is nothing but Department of Health Abu Dhabi. The ENM rules we'll discuss. So the main reason creating for the DOH ENM rules in the sense they'll be regulating the reimbursement for the general practitioners and the specialist practitioners who will be working in the outpatient settings. So in the rule effective from 15th of October 2024 onwards. So what is the documentation guideline in the sense it should be general coding documentation guidelines only as per the TASNIF audit. So however, we are following only for the general practitioner consultant. It will be capped up to level 2 only. The reimbursement of general practitioners will be involved for the family medicine, psychiatry and OB-GYN providers. It will be capped up to level 3 we can bill as per the reimbursement policy. So next is reimbursement policy of specialty consultants also we can bill up to level 3. Here the some other rules they have created. Both the actual ENM and the billed ENM should be reported on the claims. What is the actual ENM? The sense what is the predicted ENM and what we have billed that ENM. Both should be reported in the claims. Next, these rules does not apply for the emergency department ENMs and the preventive medicine services also this not apply. The above rules does not apply for the consultations. If the provider giving any consultations, that also should not apply the rules. Next, we'll discuss about DOH 24 modifier rules. Same like the Department of Health Abu Dhabi, they'll be created for some 24 modifier rules. What is the rules in the sense? Unrelated, what is the first modifier description? Unrelated evaluation and management services by the same physician during a post-operative period. So what is the use of this 24 modifier in the Abu Dhabi DOH in the sense? The modifier should be used for 100% reimbursement of the unrelated E&M services during the same patient by the same specialty by the same provider. It will be occurring within the 1 day to 14 days follow-up period. For example, today patient came with the complaints for chest pain. If the provider treated the chest pain means within the 14 days for the same problem, if the patient visited again in the same specialty provider means it should be non-billable. So if the patient visited for any other pain within the 14 days means that should be billable. In this scenario only we can use for the modifier 24. So here they have given the following are eligible for 100% E&M payment while occurring within the day 1 to 14 days of follow-up period. The subsequent E&M visit cannot be reasonably related or detected as a part of initial E&M. That was we discussed. Initially they will be treated as chest pain means the subsequent within 14 days again for the chest pain related the provider should not treat. Okay, if the provider treated in the sense they want to give the evidence and justification should be provided, then only we can able to consider. Next, referral to subspecialty consultant in the same specialty for a second opinion. So today patient came with the complaint for same chest pain. However, the provider referred the patient to particular cardiologist in the sense that should be billable for two separate E&Ms with the 24 modifier. Next, E&M visits occurring within the day of 8 to 14 follow-up period in the sense after the initial emergency E&M visit that also should be billable with the 24 modifier. For example, the patient initially visited to the emergency department for the some of the abdominal pain or some of the reason. After the day 7, the 8th day and until 14th day, they'll be visited to any other specialty provider means that is billable with the 24 modifier. So next we will discuss about consultation services. So what is meant by consultation? So consultation is nothing but the provider refer the patient to any other particular specialty providers to discuss about the patient's condition or to give the appropriate treatment for the patient's conditions. Okay, this is called as consultation. So the consultation always required for 3R criteria. What is the 3R in the sense? One is referring or requesting provider, number 2 rendering provider, number 3 report back. So what is referring or requesting? Referring or requesting is nothing but who will be refer the patient to the particular specialty provider. So that provider only call it as referring provider. For example, primary care physician refer the patient to any other cardiologist in the sense the primary care physician only considered as the referring provider. Rendering provider is nothing but who render the service. For example, we discussed PCP refer the patient to cardiologist in the sense the cardiology provider will be giving the service. Then the rendering provider should be considered as a cardiology provider. A report back in the sense the cardiology provider what the treatment they have given or what is the suggestion they will be given. No, they need to give the report back to the PCP. So who will be referred the patient? No, that provider they need to give the report back. Hey doctor, this patient for this all the problems we need to treat like this or we need to give this or all the options like that. They need to give the report back. Either should be the report back is a thank you note also. They can give the thank you note. Thanks for referring this patient under my specialty. I have treated the patient condition like that. They need to give anything should be the thank you note also. So these things must required for the triple R criteria. If the triple R criteria is not met, then we can't able to consider as a consultation services. We need to bill as it is a normal outpatient services only. And next important thing, if the consultation initiated by patient or other family members, not requested by a physician or other appropriate source in the sense, still we should not consider as a consultation. For example, who are all raised for the consultation in the sense physician assistant, nurse practitioner, doctor of chiropractic, physical therapist, occupational therapist, speech language pathologist, psychologist, social worker, lawyer or insurance company. These are all the persons can request for the consultation. For example, patient came with the primary care physician complaints of abdominal pain. The provider identified the patient having appendicitis. Then the provider will decide to perform for the appendectomy. However, patient is not willing to do the appendectomy. They want to get a second opinion. Then they directly go for any other surgeon without any requesting. They'll be directly meet with the surgeon. They'll be asking the opinion about the surgery. Then the consultant, the surgeon also suggesting the same surgery in the sense here there is no referral available. Then this will be considered as a outpatient only, not for the consultation services. That is the main reason should be consultation always required for the referring providers. So in that consultation, we have two types of code. One is called as outpatient visit, another one is called as inpatient services. So what is the difference for outpatient consultation and inpatient consultations? So outpatient consultation, the patient need to go to the specialty provider clinic and they need to get the opinion. This is called as outpatient consultation. So the inpatient consultation in the sense the patient already admitted in the hospital. So hence the hospital document they never send out the patient to outside. Then they'll be requested the provider to come and meet the patient in the hospital settings and they'll be provide for the opinion about the conditions. This is called as inpatient consultation. For outpatient consultation, we have the CPT code for 992422, 99245. For inpatient consultation, we have the CPT code for 99252, 99255 based on the level of MDM. So next we'll move on to any questions, team. Okay. If you have any questions, please post in the chat, question and answer chats. So these are all the reference material. You guys can refer it. Thank you. I'll be handing over to chapter members. I'll stop my screen. Yeah. Yeah, sure.
Hi, sir. Good morning. My name is Shruti.
Yes, Shruti.
Yeah, I have one question. For an example, a psychiatrist who is a consultant, the patient is having more than two chronic condition, and he is asking the patient to continue the medication that he has prescribed before, and he's also providing psychotherapy. So in this condition, I can go for the level 4, right? As per the documentation.
Yes, definitely we can consider for level 4. The provider mentioned about the continuing medication that should be documented in the assessment and plan, not should be in the current medication list. Okay, the provider need to mention the drug name and the dosage, everything in the assessment and plan. For example, the patient having depression and the patient also having for the some anxiety or some behavioral disturbance. Both the condition the
Mhm.
provider mentioned the medications should be continue. I have reviewed the condition. Please continue the medication like that. They'll be given the dosage in the sense. Definitely we can consider for the additional workup. Hence we can consider here the leveling and we can give the psychotherapy also separately if it is supports.
Okay, sir.
Yeah.
And as you mentioned, most of the time, what I have seen in the GP, the files, like they don't write the management plan. They will
Mhm.
just document all the areas and the prescription will be provided. So in that case, can we consider this prescription list as an, the plan?
No, that was the reason I hope the UAE documented only for capped level 3 alone. Okay. If
Yeah.
the documentation supports as per general rules and regulations as per assessment and plans separately, as per the main rules for MDM newly they implemented as based on the provider workup only we are giving the level, right? If the provider not at all
Mhm.
documented what is the workup they have performed separately in the sense we can't able to give the appropriate levels. So first thing they need to change the documentation guidelines.
Mhm.
Yes.
Okay, because we have communicated this with the doctors many times, but they are saying just see my no orders. Like I have already ordered the prescription. Then why should I repeat it again in the management plan? That's what they're questioning.
Okay. So where they'll be mentioned the orders in the subjective part or after the physical examination, like separately?
At the end. At the end, there will be prescription, like list of medicine, and there will be mentioned like for 30 days, one per day, or three
No,
times in a
list.
day, like that.
Yeah, that's correct. List of medications we can't able to consider. That was I mentioned. The provider need to
Mm.
document the condition. The condition below itself, they need to suggest the medications. Then only we can consider. List of medications we can consider it's a patient taking already the medication. Sometime the nurse also collect the history and they'll be documented in the report, right? Then now we can identify
Yes.
the provider is collected that.
Okay. Okay.
Yeah,
Okay, sir. Thank you.
thank you. Any other questions, team?